Good morning everybody. Today I am presenting slide number 5. The history given was 62-year-old male presented with tiredness, hemoglobin 7 gram percent, iron and B12 level were elevated. This was the image provided. Here we can see three medium to large size lymphoid cells with round to oval nuclei slightly eccentrically placed with open chromatin and inconspicuous nucleoli. Cytoplasm is basophilic, moderate to abundant with hair-like projections of the cytoplasm at the periphery of the cell in the background of normocytic normochromic red blood cells. Diagnosis or impression was hairy cell leukemia. Coming to review of literature, hairy cell leukemia is a rare indolent lymphoproliferative neoplasm of mature B cells with a distinct clinical presentation that includes peripheral blood cytopenias, splenomegaly, and a small number of circulating neoplastic cells with hair-like cytoplasmic projections. Epidemiology, incidence, hairy cell leukemia accounts for less than 2% of all leukemias, that is less than 1 per 10 lakh persons per year in US. More common in men than in women. Male to female ratio is 4:1. Its median age of diagnosis is around 55 years. More common in whites and less seen in Africans, Asians and Arabs. Etiology appears multifactorial, that is influenced by ethnicity and geographical factors. Farming and exposure to pesticides, petroleum products, diesel and ionizing radiations are associated with increased risk. Pathophysiology, BRAF V600 mutation is the causal genetic event in the vast majority of hairy cell leukemia. Mutation constitutively activates the protein and downstream MEK-ERK signaling pathway, leading to increased expression of genes involved in survival and proliferation and promoting leukemic transformation. Furthermore, cytokines secreted by the leukemic cells may be responsible for the areas of hypocellularity observed in some patients with hairy cell leukemia. Alternatively, impaired hematopoiesis may result from inadequate growth factor production. Pancytopenia may also result either from extensive marrow infiltration with leukemia or fibrosis induced by the overproduction of transforming growth factor beta by leukemic cells. Clinical features. Patients usually present with symptoms due to monocytopenia or pancytopenia like generalized weakness, fatigue, spontaneous bleeding or infections as a result of granulocytopenia, monocytopenia and impaired function of immune effector cells. Fullness or discomfort in the left side of abdomen due to splenomegaly may be seen. Unusual symptoms related to hairy cell leukemia are bone pain and autoimmune complications. Lymphadenopathy is not usually seen. Diagnosis is usually made on peripheral smear examination, later confirmed by bone marrow biopsy, flow cytometry or immunohistochemistry. These are two photomicrographs to show peripheral smear of patients with hairy cell leukemia. Here we can see few atypical lymphocytes with round to oval nuclei. Some are showing reniform and indentation with open chromatin and inconspicuous nucleoli. Cytoplasm is basophilic, moderate to abundant with periphery of the cytoplasm showing hair-like projections shown by arrow mark. All the cells are showing hair-like projections. This is another photomicrograph to show single cell of hairy cell leukemia. Here we can see round to oval nuclei with condensed chromatin and moderate to abundant cytoplasm showing hair-like projections at the periphery. This is another schematic diagram to show hairy cell leukemic cell. Here we can see cell which is round with condensed chromatin and abundant cytoplasm with hair-like projections at the periphery of the cell. Bone marrow aspirate is often a dry tap due to extensive marrow fibrosis. However, neoplastic hairy cells as described in the peripheral blood description can be seen. Neoplastic infiltrates can vary and they can have a patchy and subtle interstitial or diffuse solid patterns. Presence of fibrosis is common. In some cases, around 10% may show marked hypocellularity and may mimic aplastic anemia. This is a photomicrograph of bone marrow biopsy or trephine biopsy, where we can see hairy cells, hairy leukemic cells. Here we can see some of them having cytoplasm showing hair-like projections. Bone marrow IHC stain is important to appreciate tumor infiltration. Positive stains are typical pattern of B cell lymphocytes, that is CD19, CD20, CD79A and PAX5. Annexin A1 expression is specific to distinguish hairy cell leukemia from other B cell lymphomas including hairy cell leukemia variant. However, correlation with B cell markers is needed, particularly in hypocellular and low tumor burden cases, since annexin is also expressed by T cells and myeloid cells. DBA44. Combined trap and DBA44 is sensitive and fairly specific. Cyclidine D1, positive staining, dim staining compared to what is seen in mantle cell lymphoma. BRAF V600E, positive overexpression by immunohistochemistry studies. Point mutations are also detected by molecular studies. Reticulin is increased due to presence of fibrosis. TIA1 is seen in 56% of cases. Negative stains are CD5, CD23, CD10 and BCL6. Differential diagnosis of hairy cell leukemia are hairy cell leukemia variant, splenic marginal zone lymphoma, splenic diffuse red bulb lymphoma. Coming to the first differential, that is hairy cell leukemia variant, usually present with absolute lymphocytosis and less severe cytopenias. Can have similar flow cytometry immunophenotype with bright CD11C, positive co-expression for CD103 but are usually negative for CD25, CD123 and CD200. It is negative for BRAF V600E mutations. These cases can be IgHV434 positive. This is a peripheral smear photomicrograph of patient with HCL variant or hairy cell leukemia variant, where we can see two atypical lymphocytes with cytoplasmic projections, peripheral projections of cytoplasm. Coming to second differential, that is splenic marginal zone lymphoma. Here peripheral smear shows circulating neoplastic cells with cytoplasmic projections called villous lymphocytes. Usually show involvement of the white pulp in the spleen and are negative for classical hairy cell markers like CD123, CD103, CD25 and CD305 by flow cytometry. Negative by IHC for annexin 1 and cyclidine D1 and negative for BRAF V600E mutations. This is a photomicrograph to show peripheral smear of a patient with splenic marginal zone lymphoma. Here we can see two atypical lymphoid cells with round to 1 nuclei, condensed chromatin and scant to moderate cytoplasm with periphery of the cytoplasm showing irregular cytoplasmic projections, hair-like projections. Coming to third differential, splenic diffuse red bulb lymphoma. Here patients can present with splenomegaly and are positive for CD11C. Negative for classical hairy cell markers like CD23, CD103, CD25 and CD305 by flow cytometry and negative by IHC for annexin 1, cyclidine D1 and negative for BRAF V600E mutations. This is a peripheral smear photomicrograph of a patient of splenic diffuse red bulb lymphoma. Here we can see atypical lymphocytes with round to oval nuclei with condensed chromatin and regular nuclear border with scant basophilic cytoplasm and cytoplasm showing at the periphery broad based cytoplasmic projections, better seen in that inset where we can see cytoplasmic projections at the periphery. Thank you.